Hey guys, this is Vicki. Let's take a look at economics and the impact on healthcare. So when we think about economics, we definitely know that we are currently experiencing and have been experiencing change in the healthcare environment. We are really went from illness emphasis to more of a preventative type of approach to care. So most insurance companies now are mandated to include preventative care to identify and treat patients early. We want to manage care before acute care services are really required to help save money. So some of the things that I look at that we've implemented with great success over the last few years is really phone triage, nurse protocols. We think about Coumadin clinics, outpatient type clinics. Like I said, making sure that everybody gets in for their yearly preventative exams so that we're on top of high blood pressure so we're not hurting the kidneys, making sure that we're monitoring hemoglobin A1Cs, things like that, to ensure that we've got the patients on the right track to health, or at least to maintaining a disease at a current level so that it's not progressively getting worse. The second area that we really changed was from independent decisions to really best practice. So facilities, providers, nurses really have strongly looked at evidence-based practice and what is the best practice? Have they established protocols? And in many diseases they have. I use congestive heart failure as an example. Many years ago the treatment plan may have looked different. However, now it's important that all patients are on an ACE inhibitor or an ARB if they can't tolerate an ACE, that they're on a beta blocker, preferably corvalolol, that they've received an echocardiogram, that we know what their ejection fraction is, that they're being closely monitored, that they're being provided all of the same similar nursing education in regards to salt intake, diet, activity, fluid intake, things like that. So there are standards of care that need to be followed to ensure that the patient is receiving best practice. The next area is really, we move from an inpatient environment to an outpatient. So many procedures and surgeries are now outpatient rather than inpatient. And they can include, maybe heart caths, stents. Many procedures are done not even at the hospital in their surgery suites, but they're done at clinics that are detached from the facility, rotator cuff, things like that. So many procedures are being done outpatient and having the patient go home to help one, save money, but two, also to prevent further complications, MRSA exposure, pneumonia, things like that. We also have payment methods. So we originally had, we're moving away from independent cost setting where different organizations could set their prices to more of a managed care or prospective type where the federal government and private insurance are now managing their healthcare services and payments are more closely monitored. Many cost controls are also on pay for performance. So hospitals are paid better for improved outcomes such as avoiding ulcers, infections, etc. We also know that healthcare attitudes have changed and that consumers are very driven. They're more educated. There's many more resources for them available via the internet. However, it is still important that they understand which sources are good, making sure that we refer them to the right places and they're not just going out on any site. So I would take a look in your spare time and see when a patient asks you questions, where could you refer them to? WebMD, Mayo Clinic, things like that. We don't really want them on Wikipedia or just forums because what they're actually getting may not be legitimate information. We're also moving from no insurance or underinsured more to this healthcare reform. Now that's kind of a work in art, but we'll kind of see where that's going. You can click on this link. There is a video if you have this in full view. So what underlying themes really have driven healthcare financing? You can take a minute and maybe write them down by pausing the recording, but I am going to go through a few. One is inflation. So the price of health care really has outpaced inflation. Physicians' salaries or providers have risen faster than the average worker's earnings. And really the public is becoming better aware, but for most part they're unaware of what prices really do cost. CT scans can be upwards of $3,000. So many times families or patients aren't aware of what truly things cost. Technology has definitely driven healthcare up. So the state-of-the-art technology and the need to diagnose and treat people earlier, 3D ultrasounds for expectant moms, cardiac CTs, potentially to diagnose heart disease. For sure, the aging population, right? The baby boomers are now seeking a greater need for healthcare services. And most boomers qualified for Medicare or started to qualify for Medicare in 2011. So we're really starting to now see that more and more and more people are qualifying for Medicare type healthcare insurance. We definitely have more chronic disease. If you remember back from our ethics lecture, we're keeping people alive longer, and we're providing them with more medications and more treatment procedures to keep their chronic diseases more intact. Prescriptive drugs have really, the price of them, just advertising alone, has really put a hamper on our ability for the healthcare to remain at a good price. I mean, if the medication is not generic and it's in the research, or it's just out brand new, it's usually very expensive. So it's something that as nurses you have to consider, is the patient going to be able to afford what the provider has prescribed? If not, you need to be the advocate. Administrative costs have went up. Consumer utilization of healthcare. It is changing to preventative care, but some are still old school, and so we have a ways to go. And then for sure, like I said, pay for performance. So the more successful a patient is, the better the organization is going to be compensated. This is just a little graph. You can take a look at it. And what it's really depicting is by 2013, healthcare costs are anticipated to drain 25% of the United States resources. Although the health economy shares a tight connection to the overall economy, usually it cycles, it lags behind just a little bit. So we're coming out of the economic depression, and so we are starting to now see that the effects of that is starting to come back, in which people are now starting to see wanting to get their health care needs taken care of because they can't afford it. If you take a look at this slide, I just wanted to put this on here because it does depict where most of the money does go. If you can see, the majority is really the hospital care, right at 31%, but the next biggest place where healthcare expenditures is in the physician and clinic services, followed by prescription drug at 9%. So that is really where the most of our money is spent in healthcare. I would love to see this shifted to 31% as preventative care. I don't know if we'll ever get there, but it sure would be nice. Now, when we think of the uninsured or underinsured, hopefully we're starting to see a shift in this, and as you can see, since healthcare reform has started, we did see a slight decrease in the number of uninsured people under the age of 65, down to 40.7 million, approximately, in 2014. But we do know that this is a serious problem because when a patient is either uninsured or underinsured, it generates uncompensated care or indigent care. And it's bad debt for not only providers, but also for healthcare organizations, health insurance companies, and consumers. So when there is this uninsured or underinsured, the facilities still, in order to keep their doors afloat, they often do what's called cost shifting. So unpaid costs really must be covered by those who can pay. So providers may increase their charges for private and public insurers. There are some organizations, and I know that Aspirus and Ministry does contribute money to a fund for underinsured populations, uninsured or underinsured. They do typically have to apply for this type of funding, but oftentimes it is available. So if you have somebody who you know is not insured or is financially not in a good spot, you may want to get social services involved, and they may be able to help that patient out with being able to apply for some of the financial assistance that hospitals do create for situations like this. You know, and when we think about uninsured or underinsured populations, I don't want you just to think of the individuals who are living on the streets. Many times we have working poor, meaning that they are employed by small businesses without insurance, or maybe don't contribute a lot of money to helping pay for the insurance. Many times there are part-time workers, and then for sure there are unemployed people, but a person could be working full-time and just not being able to financially afford to purchase insurance or make the co-pays for that. We also know that there is Medicaid, and that is a federal health insurance program within each state, and it is intended to improve the health care for the poor. Unfortunately, the poor are less likely to use preventative services and are more likely to be hospitalized to avoid conditions. Or for avoidable conditions. So what we could potentially see as preventative care, they wait and wait and wait and unfortunately have to be admitted, which is going to cause even more debt. So when we think about healthcare key participants, there are really 5. Obviously the consumers, so the key focus of today's, is consumer focused, the Accountable Care Act. There's within consumers is the population, race, education, employment, and then the generations of individuals that we see in the different viewpoints that they bring with them in regards to medical care and coming in for medical treatment. We also have providers, so obviously nurses. We're the single largest class of healthcare providers. Approximately 50% of the workers are in an acute care center. Physicians, right? Healthcare systems would also be in here, so hospitals, clinics, outpatient systems, and then the government is a provider. So they're not only regulators, but they're also a large purchaser of care. They pay for approximately 1/3 of all medical expenses, and they also provide care such as the Veterans Administration, the Indian Health Services, and they have their own public hospitals, academic centers. We also know that another key healthcare participant is suppliers. So oftentimes organizations are involved with group purchasing organizations, and these are people who really send goods to the clinics and hospitals. So some of the suppliers that you may have seen is obviously for goods and foods, but beds such as Stryker, maybe Medtronics for pacemakers or defibrillators, different pharmaceutical companies, Eli Lilly. And then we have the regulators, and that's really the government, so the both federal and state. And our payers, which is our insurance companies. So when we take a look at this slide, we look at the sources of healthcare financing, and as you can see, if you're 65 years or older, the majority of the medical bills being paid is through Medicare. If it's less than 18 or 18 to 64, it's by and large most part private care or TRICARE, which is for military. So I just wanted to show you just kind of how, depending on the age group, where most of the funding is going. Now when we specifically look at Medicaid, Medicaid, depending on what state you're in, is a federal health insurance program, and we do have that within Wisconsin. The goal is really to improve healthcare access. Medicaid is available to anyone who's 65 years or older, or is blind, or is disabled. Each state does establish Medicare eligibility criteria based on their aid to families with dependent children, income and eligibility levels. So within Wisconsin, we have Badger Care Plus. It may be now called something a little bit different, but it's very similar. And Badger Care Plus is for families with children and they do have to be at or below the federal poverty level, depending on the size of the family and the children that are involved. So you can take a look at that. If you want to go on to Wisconsin's website for this, you can just type in Badger Care. You can take a look at some of it. I'm not expecting you to 100% understand, but do know that with the new healthcare reform, Wisconsin has chosen to not expand Medicaid benefits. But if an individual is living in a state that isn't expanding Medicaid, the individual may not qualify for either Medicaid or reduced costs. Oh, just forget it. Just take a look at the Badger Care Plus. Just know that it is available yet in Wisconsin. Now, when we think of Medicare, we take a look and we know that Medicare is the largest health insurance program in the United States. It was established by Congress in 1965, and it's funded through the taxes on our wages. So if you're working, you are paying Medicare. The eligibility for Medicare is anybody at or older than 65 years old, people less than 65 with certain disabilities, and people of all ages with end-stage renal disease. We know that Medicare usage is on the rise because of the baby boomers and increasing elderly population. And this is a major factor in creating the federal budget deficit. We know that also that Medicare only reimburses at a rate of about 60 to 70% of the billed cost for the services. So what a normal insurance company would pay for, Medicare doesn't pay it at 100%. So most of our retired individuals do receive Medicare. Now the type of Medicare coverage that they have is dependent on what they've elected to either have or purchase. So Part A is hospital insurance, and an individual is automatically enrolled when they join Medicare. And please know that when a person turns 65, there is quite a bit of paperwork and physical exams that providers do need to make sure that the individual is going in and having these done to be able to qualify for Medicare. Most people don't pay a Part A premium because they have met the Medicare taxes while they were working. And this covers mainly inpatient care in hospitals, so critical access hospitals, inpatient rehab, and long-term hospitals. It also does cover inpatient care in a skilled nursing facility for potential rehab, but not long-term care. Part A will also cover for hospice and home health and some home health care services. Now Part B, on the other hand, is a voluntary medical insurance. So individuals who choose to purchase Part B, it does help cover medical necessary services such as doctor services, outpatient care, and some parts of home health services, also durable medical equipment, and it does cover preventative services. Like I said, the participant does pay a Part B premium each month, and they will more than likely pay some type of premium. Part C is the Medicare Advantage, and this is another Medicare health plan choice offered by private companies approved by Medicare. The plan will provide all parts of A and B coverage, and it'll usually cover vision, hearing, dental, and health and wellness programs. It does also include some parts of Medicare Part B, which we'll talk about right now. So Part B is a prescription drug coverage. So participants will pay yearly deductibles, premiums, co-pays on drugs, but it is a type of prescription drug coverage that an individual has to elect. Now this can be very confusing and things often change, so my suggestion to you is if a patient has or family has a question about Medicare coverage, I would strongly have you refer them to a case manager or social worker so that the questions can be answered as most accurate as possible. So when we think about federal reimbursement, we know that this is critical because Medicare is one of the largest payers of hospital charges. So Medicare created the diagnosis-related groups, or DRGs, in 1983 as a result of rapidly increasing healthcare costs and increased use of hospital services and a wide variation in the cost of care among the hospitals. So what maybe an appendectomy costed over here, it was $2,000, and at the other hospital they charged $3,500. So they wanted to ensure that no matter where you went, that the fee that was going to be charged was the fee that was going to be charged. So really, why the change, like I said, was to promote effective and efficient care, promote early discharge and improve care, and utilize utilization review nurse involvement to ensure that the patient is on the right path and able to decrease the costs. So a DRG is specifically a pre-established amount of money that Medicare will pay depending on the patient's medical condition while in an inpatient hospital. So each patient is assigned to a diagnostic grouping based on their admission diagnosis, and payment is pre-established, like I said, for each diagnosis in an inpatient setting. And this doesn't so let's just use an example. Let's say you have a patient who comes in with congestive heart failure. And let's just say that the congestive heart failure DRG says that the hospital will receive $1,000 per day for 5 days. If the patient is safely discharged in 4 days, then the hospital profits $1,000. If the patient is not discharged for 6 days, the hospital only gets paid for 5 days. So the impetus is that we want to treat the patients well and get them out of the hospital, or make sure that they're at least on course to be able to leave. When we think about the Affordable Care Act, we know that this took place back just a few years ago, but it is the health insurance marketplace that was effective, there you go on the slide, January of 2014, and is at times still getting reworked. I do encourage you to take a look at the video that I had put in Blackboard, because I think that the cartoon, the Kaiser Obama cartoons do a pretty good job of it. The video that's 9 minutes is a little bit older, but it's still good. And then there's a minute that's about 6 minutes 52 seconds long. But we know that the idea was to get all people insured. And so in order to have this, everybody needed to be eligible. So to be eligible for the Affordable Care Act, they must be living in the United States, must be a U.S. citizen, and can't be currently incarcerated. So if you qualify, you can compare plans based on price, benefits, and other features, but there are typically 4 categories. There's a bronze category that covers 60% of the total average cost of care. There's a silver, which covers 70% of the total average cost of care. There's a gold that covers 80% of the total average cost of care. And then there's a platinum that covers approximately 90% of the total average cost of care. However, as an individual goes up, bronze, silver, gold, platinum, the cost of the premiums do obviously increase substantially. So when individuals are looking at these plans, they not only have to outweigh, are they a sick individual? Would they be using the plan? Where's the best bang for their buck, depending on their health status? Now know that in 2014 there is a penalty, or there are penalties. So for example, if a person doesn't have coverage in 2015, they'll pay the higher of 2 amounts. The first is either 2% of their yearly household income, or $325 per person for the year for an adult, or $162 per child under the age of 18, with the maximum penalty per family of close to $1,000. So know that there is a penalty, and I would assume it comes around tax time when you have to report whether you have insurance or not, things like that. I don't really know the logistics of it, but I assume that the government has something figured out for it. So if we take a look here, I just found that this was kind of interesting in that the thousands of residents, we can see that there has been a decrease in the number of uninsured individuals by almost half, at least in Wisconsin. So that is great to see. Now, now if we start taking a look at private healthcare insurance, we know that before the 1930s there was a self-payment was very common. I've actually even heard stories of like people bartering with chickens and all this other crazy stuff to be able to get healthcare, and I think in Alaska that still might happen. But know that there was the shift for fee-for-services also to this managed care organization, much like Medicare and Medicaid did. So they set certain fees up, and that's just what the fee was going to be for the service that the patient received. We know that for the most part, individuals do get their private health insurance through their work, although now some are having to go through the health care reform. So when we look at managed care organizations, we know that the goal was to reduce medical costs by reviewing and providing oversight of healthcare costs. And we know that there are really two major managed care organizations. One is the HMO and two is the PPO. So let's take a minute, we'll take a look at each of them. When we look at an HMO, a health maintenance organization, we know that there's an annual payment is made by or for beneficiaries to a group of providers that deliver all of the healthcare services provided under the plan, including physician and hospital services. So HMOs, in layman's term here, provide comprehensive care, which include the physician's visits or provider's visits, hospital stays, emergency care, surgeries, labs, x-rays, so on and so forth, okay? The HMO arranges for this care either directly or in its own practice and or through the doctor or healthcare professionals under contract. So when we have a health maintenance organization, the disadvantage is that patients really has a little less responsibility. They do have a few less options, but sometimes the costs can be less. What we are seeing is that most are shifting away from the HMO and really going more towards the PPO. So when we look at HMOs really quickly at a glance, we know that it encourages preventative care because with the healthcare reform, this was a requirement. Members do pay a monthly premium, but the primary care physician really manages and coordinates all health care. So in order to see a specialist, the patient does need to see the primary care physician or provider, and that provider needs to manage the care. So let's just say that Jake was in the office and he was having acne. And if he just wanted to go see a dermatologist, he would still need to go see his primary care provider, and then a referral would have to get sent over to the dermatologist in order for him to be seen. If that's not done, the patient may be charged differently because the PCP did not manage or coordinate it. Anything out of network has to be pre-approved, and services that are not recommended by the primary care provider may be refused and not paid for. And the HMO directs and pays the physician monthly, in some situations at least. So sometimes the physician or provider or the organization is paid a flat fee each month for each of the patients on his or her list, whether the doctor or the provider actually sees the patient that month or not. It's called the capitation plan. I don't really see it used as much, but some facilities may still use it. So this is kind of where we just explain it really a little bit. So an HMO method of reimbursing healthcare providers, the cost does not vary even if the employee uses the healthcare services or does not use the healthcare services. So the provider is being paid either way, or the organization. So obviously the emphasis on wellness, disease prevention, and patient self-management, because if they're not being seen, they're still getting paid. So the emphasis is really to keep the individual as healthy as possible, because then they're really getting paid to keep them healthy. Now when we look at PPOs, on the other hand, a PPO is a preferred provider organization. So the PPO contracts with a network of preferred providers from which the patient can go and see anytime he or she wants. So the patient does have more responsibility, but they can see many different providers or different specialties as long as the patient or as long as the provider is within the preferred network. So when we look at this plan, the primary care provider agrees to provide services at a decreased cost. The PCP agrees to not bill the patient for a difference in billing. So let's say an x-ray was $100 and they've negotiated it down to $80. Then that's all the patient can be paid for is $80 because of the agreement that was created. There is quite a variety of healthcare plans. Most of the time include premiums, deductibles, and co-pays. The member can select their own primary care provider. But like I said, an individual doesn't need to have a primary care provider, but if they do, they should be on the preferred list. And if they want to go see a specialty services, if Jake wanted to go see a dermatologist, he wouldn't per se have to be referred from his primary care provider. As long as the dermatologist would be in the preferred network, he would be able to go and see that provider. Okay, so let's take a minute really quickly and we'll talk about, you can pause this if you want, but we know that nurses do have an impact on healthcare costs. And so pause it and do try to think of some things that we can do that increases and decreases healthcare costs. A couple things that I had written down, at least for increasing, is that RN poor quality, maybe wasting supplies, maybe breaking sterile technique, a patient gets a UTI, we're not observing skin, we don't see pressure ulcers, the hospital's not reimbursed then for the pressure ulcer that was pre-admitting. So making sure that we do proper assessments and documenting them all the time is very important because it can potentially increase the amount of cost. Cutting corners that can potentially harm the patients definitely increases cost. Not following evidence-based practice can increase costs. So what can decrease cost? Just some things I put down is providing cost containment, so getting in and out of work on time, so time management, getting work done, being a team player, problem-solving dilemmas, providing excellent care for less money, so utilizing the evidence-based practice to improve quality, making sure that you're being the advocate for the patient. So if you know that the standard of care for congestive heart failure is ACE inhibitors or an ARB, beta blockers, and an echo, is that on their current plan of care? And if not, we need to be advocating and saying, hey, we don't have this patient on a beta blocker, how come? Knowledge is also a big thing. So the cost of test, equipment, and potentially the length of stay. And I think one of the biggest things is providing preventative education and trying to do our best to keep the patients out of the hospital. So that ends our lecture on economics. If you have any questions, please let me know.